We're going to be speaking to delegation. This is often a topic that promotes a lot of questions, and that's a good thing because in your mind, as you begin to review and rethink through the process of delegation, you begin to automatically apply it to situations that you've been exposed to or your students are experiencing. What I'm going to ask you to do, because questions can be many, and they really are pointed toward a person's personal experience on a campus. And I would really like for more to benefit from what we learned today. So what I'm going to ask you to do is that as you think of questions, you write them down. And then this weekend, you'll be doing your homework, one of which is to read 225 rule in the BON. If after that time your question has not been answered, then certainly submit it by email to your nursing supervisor. What we're going to do is begin to post those on the website so that all can benefit from these questions because they're excellent questions. And it's empiric knowledge that you're bringing forward. This is what you've experienced on campus, and it's the actual application of the delegation rules to those experiences. So more than those that are in this room need to benefit from that information. So I'm not stopping for questions. I want you to write them down, do your reading, and then submit that to your supervisor, and we will post it with an answer. It may also require someone else to give input to this. So that allows that to take place too, because your situations are many and they're always unique to the students that you serve. Both the presentations by Melinda Hester, the school nurse from the Board of Nursing, and Johnny Jalla, the legal advisor in the district, one of the legal advisors. We plan to put them on a webinar, not together, but individually on our website. At the very least, we can certainly put up Johnny's PowerPoint and put that on the website too. But I really want you or some nurses to have the opportunity to ask questions in a webinar. We'll do that. It allows those responding from the sites to benefit by way of question and answer. So let's begin. The presentation today is by Melinda Hester, and I will be going through that with you. She starts first with Florence Nightingale. Florence says, "But in both hospitals and private houses, let whoever is in charge keep this simple question in their head. Not, how can I always do this right thing myself, but how can I provide for this right thing to always be done?" Next, you would see the actual website of the BON, and you see down your right is I guess it's the left. You see the delegation resource packet. That's where the packet is located on the website. So if you will just click there, then you can pull down all the resources that registered nurses are provided in Texas. You also have the nurse practice information there where you can go for your Nurse Practice Act. When you actually go to the delegation resource packet, in the middle of this paragraph, it says, Rule 225, RN delegation to unlicensed personnel and tasks not requiring delegation in independent living environments by clients with stable and predictable conditions. That's the piece that we're going to be exploring. So we talk about defining delegation. We talk about the unlicensed assistive personnel, which we refer to UAP. Who is a UAP? Call out a title of a position. TAs, UGCAs, Teachers? Coaches? Office clerks? What about the principal? Yeah, he's a UAP, right? He doesn't have a license as a healthcare provider, does he? No. Okay, so essentially, everyone on your campus, except if you have second nurses on your campus, the other RN is not a UAP. So everyone else are UAPs. So it says, basically the UAP provides nursing-related services while the RN retains accountability. The RN transfers responsibility for performance of a task to the UAP. This is all part of delegation. The RN retains accountability for client outcomes. In our circumstance, it's student outcomes. The purpose for delegation, collaboration. This is one reason why we choose BSNs over ADNs, LVNs, and the like in health services and Dallas ISD. It's because you are prepared both as a manager and as a leader to provide collaboration and leadership on a campus. You are unique in that way by way of your undergraduate preparation. So collaboration, participation, retaining control, least restrictive environment, we've heard that more than once today, clarifies the scope of the practice, and guidance for safe practice. This is all under the purpose for delegation. And you as a BSN or MSN or doctorate in nursing provide that leadership on campus. We talk about an independent living environment. That's us. That's schools. So the settings that do not require continuous nursing services are community-based settings, homes, group homes, assisted livings, and schools. So when the BON talks about schools in their rules and regs, they're talking about an independent living environment. So we're now talking about the application of delegation as it requires, as it applies to a UAP. They're number one, they're not licensed. Number two, they're monetary compensated. They have various titles, and the RN's duty is to provide for patient safety. RN and LVNs. Now we talk about LVNs, but we don't have LVNs serving, right? When would we come in contact with an LVN and what we do every day? Private duty nursing. And we'll talk a little bit to that. In the private duty nurses that serve our students, there's not many. But we do have a responsibility when they're on our campus. Because they are serving one child does not negate your responsibility to that child. That child is on your campus. That is one of your students, and your responsibility is there to be sure that that child gets what they need. So the RNs do not delegate to LVNs. I think you know that. They supervise and make assignments. LVNs do not delegate to UAPs, but they may supervise and make assignments. So training versus delegation. When we talk about training here, we're talking about the training that you provide for a UAP to do a specific task. So the mere act of training does not mean delegation. Teaching a client's family, which is a student's family, to do something or to do a task related to their health care is not delegation. Supervision versus delegation. So you're defining supervision as an active process. It's going on, it's constantly moving during the day, every day, of directing, guiding, and influencing the outcome of a person's performance of a task. And that's whether you are on the campus or not. So we will talk to that too in a minute. So the mere act of supervision, again, is not delegation. So the benefits of having delegation allows the RN to attend to more complex patient care needs, in this case student care needs. You have a whole campus to serve. Develops the skill and competency of a UAP. By your training, you're developing that competency of that UAP. And promotes cost containment. The gatekeeping criteria for delegation. Number one, it has to be an independent living environment, schools. Number two, the client, which is the student, or the adult responsible for that student, which is usually the parent, is willing and able to participate in decisions for that child. So you can have a child that is very verbal and can talk and say, oh, that doesn't feel good, or be able to give you information back, especially an older child. But then you can have either a young or an older child who can't communicate. But that caregiver, that adult in their life, can certainly be involved in the decisions in which they make. So number two criteria is yes, that we have both either the student or the student's adult that can be part of the decision making. And then number three, that tasks are related to is stable and predictable in healthcare conditions. We're going to speak to that too in just a moment. All right, exclusions from 225. What is not counted under 225? Gratuitous nursing care, faculty and preceptor are part of an education course. So that's the schools of nursing. When you have a student preceptor on their campus, they are not delegating, even though, and they're not RNs yet either, but they don't have the permission to delegate on a campus. That is still your responsibility. RNs assign tasks, supervises other licensed practitioners, and those people are oftentimes the second nurses on a campus. And then the UAP that's directly assisting. If you have a UAP right next to you and they're helping you do a cath or whatever, you're not delegating to that individual. They're merely assisting you at that point. So let me mention one thing here. I continue to get feedback, not a lot, but I get pushback from nurses that are either not accepting of their second nurses on campus or their paraprofessionals on campus, or the other way around. The second nurse on a campus or the paraprofessional that may have 5 schools, a school every day, that they don't want to go to because they don't feel welcome. That stops. No more. Number one, if you're on a campus that is so large that you have an additional allocation of a day or more, be very grateful. I would think you have enough kids on that campus that getting the state mandates done and all the required screenings that you have to do and the immunizations, that you would welcome a professional or a paraprofessional on your campus to help you. And I expect you to be a professional, to be a leader, and to discuss the assignments that both of you can contribute to the time that that person is on your campus. I don't want to hear any more of this stuff, because you're just not even appreciating the benefit that you have and actually that the district has provided for you. When I came into this role in 2003, the nursing ratio at that time, nurse to student, was 1 to 1350. That's what every nurse had. So I slowly worked at that to bring more nurses on board so we could lower that ratio. It's not where I want it to be. I want a nurse in every school. But what happened with the allocation about 4 years ago, it became equality across the district. In the past, a nurse in school of 125 could have a nurse full-time, just because it was a tradition. or because of some other reasons. Whereas a nurse with maybe 5,000 would only have one nurse in that building. There was inequality across the district. So with the allocation formula began the equalization of health services across the district. It is now a 1:750 ratio. So it's a lot less than where it began some years back. And I hope that in the future we can continue to move that forward. In the meantime, because you have extra allocations on your campus due to the fact that you have a large population to serve, and as a school nurse, you are responsible for doing all the screenings, whether they're in high school with new to district, whether they're in pre-K with new to district, or any of the other grades in between. You are responsible and accountable to be sure that every single one of those children have had their screenings, that every single one of them are protected from vaccine preventable diseases. Those are the very, very basics. I would see that as a proficient level if you were 100%. So if you are in a big school and the challenge is there by the numbers, certainly use your people that you have as an extra allocation to help you meet those needs. And when that extra person is in your building, you need to be also down the hall in that special ed unit and observing those children so that you get to know those families and those children, and to be sure that the procedures that are given and provided for those kids are adequate for what their needs are. Last year, in a district very close to us, there was a lawsuit, and the lawsuit was against the school nurse and the district, because during a feeding tube procedure, the parent felt that the equipment was not cleaned properly. Are you ensuring that not only a child is being fed, but when the equipment is not being used, it's cleaned properly? What happens inside a G-tube with milk and formula in it? What does it provide? A medium for things to grow. Then that child is fed, and whatever is growing there now goes into the stomach and can cause some very serious illnesses. Have you ever looked at the cleaning that goes on with the G-tubes and or trach tubes and nebulizer tubes? I mean, we have plenty to look at. So be sure that they're cleaned properly, and when they are no longer adequate for use, that they are replaced in a timely manner. But these are things that having a big school and having an allocation, an extra allocation, can afford you that time to make sure that children are getting quality services on a campus. Rule 225, there are 3 levels of task. There's ADLs, there's HMAs, which is health maintenance activities, and then there's nursing tasks. If you're not familiar with ADLs, those of you that have ADL units, I'm sure that you do, but that would be bathing, dressing, grooming, routine hair and skin care, meal preparation, feeding, exercising, toileting, transfer, and ambulation. Those are basic ADLs. Anybody that is expected to be able to do those things is considered an ADL, but not all people, not all children are able to do those by themselves. Then the HMA, which is the health management activities. They are usually at a little bit higher level than an ADL, but it could be the administration of oral medications, bowel and bladder programs, including suppositories, enemas, manual evacuation, intermittent catheterization, digital stimulation associated with bowel program, tasks related to external stoma care, including but not limited to pouch changes, measuring intake and output, and skin care surrounding the stoma. This is straight out of your Nurse Practice Act. So when you read your 225, you'll see that referred to. I'm going to read you the definition of the independent living environment. I apologize for reading, but some of this is so specific, I don't want to miss a word, but they're short pieces. Again, out of your Nurse Practice Act. Independent living environment, a client's individual residence, which may include a home or home-like setting, such as the client's home or entity licensed or regulated by the state or federal agency, or exempt from such licensure and regulation, a group home, foster home, assisted living facility, and includes where this client works, attends school, and engages in community activity. The term does not include setting in which nursing services are continuously provided. So that is independent and living environment. And we were talking about 3 different levels of delegation, and the nursing task we will come to again in a few minutes. RN accountability. The RN must perform an assessment to determine if the ADL and the HMA may be exempt from delegation. Also, the ADL and HMA does not require delegation. The RN is not accountable for the actual performance of the ADL and HMA. As a school nurse, would we ignore an ADL being provided or an HMA? No. We would certainly know by visiting that classroom to be sure that those needs are being met. Let me ask you a question. I get this question not very often, but on occasion. We already know that some of our special ed kids are in regular ed classrooms, and that sometimes in those classrooms there are diapering that needs to occur. It's unfortunate that a nurse would refuse to care for a child in that situation. In those regular ed classrooms, the classroom teacher that usually has about 22, 23 kids cannot stop in the middle of a classroom and change a diaper. So this is an ADL, right? Diapering, toileting would be part of that. And you would step up to the plate and provide privacy for that child to do that. This also transfers over to soiling. We're not going to allow a child to sit in soiled clothes all day just because we don't think it's our responsibility. Unfortunately, some nurses have felt that way. So again, that's an ADL. We would call a parent if the parent is not there, and we make sure that in the future clothes are provided for that child, and we assist that child in getting cleaned up and getting into clean clothes. Now, if that means that someone is with you when you assist that child, then make that happen. But you can't leave a child soiled or wet for long periods of time just because either you don't think it's your responsibility, you don't do ADLs, or you think that somebody else has that responsibility. You know, whatever it is, you need to solve it. And you can work again collaboratively with your staff. Okay, what's important about this is to show that ADLs in most cases are not delegated tasks. So there are exceptions to that, and that basically you're not responsible for the accountability of that, but you know as a school nurse on your campus, you are responsible for the health needs of that child. Okay, then you do an RN assessment. You're determining at this point exactly what needs to be delegated and what does not. The ability of a client or a CRA, and that was the adult we talked about earlier, to participate in the health care decisions. So if you have a child and a parent who is not able to participate for whatever reason, this may mean a situation in which delegation is necessary, even if it's an ADA, ADL, and an HMA. Adequacy and reliability of the support system. Degree of stability and predictability of the student's health status. Knowledge base of the student and CRA ability of the client or CRA to communicate with the UAP, and frequency of reassessment. By reassessment means how many times have they gone back to the ER, how many times have they gone back to the doctor. You're establishing stability and predictability. So I'm going to read again, one paragraph again from your 225 about stable and predictable to help you understand those two words. Now in our minds, we are dealing with pediatrics, and I know in my mind, pediatrics, they can crash, and they can crash quickly. And in that population, we always keep that in mind, and there are times when we think there is no stable or predictable situation because anything can change. But in reality, that's not true. So the definition of stable and predictable, a situation where the client's clinical and behavioral status is determined to be non-fluctuating and consistent. A stable and predictable condition involves long-term care needs which are not recuperative. In other words, you're not in rehab and you're not currently recovering from a situation in nature and do not require the regularly scheduled presence of a registered nurse or licensed vocational nurse. Excluded by this definition are situations where the client's clinical and behavioral status is expected to change rapidly or in need of continuous assessment and evaluation by the registered nurse or licensed vocational nurse. The conditions of a client receiving hospice, this is the example. The condition of the client receiving hospice care in an independent living environment where deterioration is predictable shall be deemed as stable and predictable. That's their example. So I know there are many gray areas, and in your mind you're probably thinking right now, I have this student, is this predictable and stable? One of the things you consider, when was the last time this child was in the ER? Is the child ending up in the ER every week? Is he having to go through reassessment by the medical team frequently? Then yes, it's becoming unstable and perhaps not predictable. But if this critically cared child with a trach and G-tube is not seeing their doctor other than the regular scheduled appointments, is busy and active on your campus, and there hasn't really been any change in the health status in some time, then he is predictable and stable, even though he's got a trach, a G-tube. But if, for instance, where this kind of escalates up is our kids with vents, and or I'm sure in the future we will be having kids with IVs. Many districts are already dealing with that. So those move into the realm of nursing tasks and become a little bit different when we address those on a campus. Assessment continued. So based on RN's assessment, ADLs and HMAs can be exempt from delegation, or ADLs and HMAs can be delegated to a UAP. That's a decision to be made. Or qualified as a nursing task that cannot be delegated. And we spoke a little bit about that as far as vents and IVs. Those would not be delegated. Delegation criteria. The RN must determine the task not required, the task does not require nursing judgment. The UAP's competency, the level of RN supervision, the 5 rights of delegation, which again is very clear in your delegation packet. If an employee has written a policy stating the decision to delegate is the RN's. Now, fortunately, in downsized T, that has not been written, which is in our favor. But I will tell you that in our policy, and it's DFAB, legal, which means it comes out of TASB and is a legal policy across the Texas. It defines the nurse. The nurse means an educator employed to provide full-time nursing and healthcare services and who meet all the requirements to practice as a registered nurse, RN, pursuant to the Nurse Practice Act and the rules and regulation relating to professional nurse education, licensure, and practice, and has been issued a license to practice professional nursing in Texas. So that in itself binds us to our Nurse Practice Act and is recognized by the school district. So we, functioning under Rule 225 or any other rule or reg of the Nurse Practice Act, will be held responsible for that. Tasks that may be delegated. ADLs and HMAs that require delegation. And let's do that now. When we're talking about tasks that may need to be delegated, I'm going to again read from 225 an example of some of those that you would actually delegate. And one of them sounds a lot like an HMA. So inserting tubes in a body cavity or instilling or inserting substances into an indwelling tube limited to the following. A, insertion and irrigation of urinary catheters for the purpose of intermittent catheterization. B, irrigation of an indwelling tube such as a urinary catheter or permanent placed feeding tube. These may be at the level of delegation rather than a simple HMA. So it depends on the situation. It needs to be looked at by the RN. Your 5 special needs nurses can assist you in that decision making. The next category is tracheal care, to include instilling normal saline and suctioning of a tracheostomy with routine supplemental oxygen administration can be a delegated task. In addition to that, administration of medication, vaginal rectal suppositories, and oxygen administration for the purpose of non-acute respiratory maintenance. All of those can be delegated. More task is, of course, again, tracheostomy care, including the installation of normal saline. This is what I just read for you. Care of the broken skin with a low infection risk. Sterile procedures involving wound and/or anatomical site. And then the administration of medication, which you are all very familiar with, which is your oral via G-tube, sublingual, topical, eye, vaginal rectal suppositories, unit dose, and that's your MDIs. O2, the routine O2, use of pill container. We don't use that very much. That's where you put in the regular pill containers, and some nurses in some situations put the dosages out there, and then the UAP administers those. But where we do run into that is when we are preparing for a field trip. And accessible to you are the little pill envelopes with you where you can put the information down. We have those in stock now, and you can request those from Sonia, and she can send you out, 5 or 6, whatever you need on your campus for field trips, which enables you to give a unit dose to that UAP that's traveling with that child on that field trip, with the directions on it and how to give it. And then, of course, insulin. And this talks about the pill reminder containers, and again, we don't do that except for the little envelopes. Then insulin administration. The nurse needs to be available at all times. What does that mean for us? It means the nurse needs to be available at all times. So, if you are at another campus, are you available by phone? Yes. Are you on a campus? Of course, you're available then. If by chance you are ill, injured, family's ill, injured, and you can't be at school, then an RN needs to be available. That means you need to let your supervisor know. so that she's aware that you are not there, and if there's questions, it can come to her and or the emergency network nurse. So an RN needs to be available. Doesn't mean they have to physically be there, but they need to be available for questions. Sometimes they will need to be physically there, and we're lucky that we have a diabetic educator on our team, which is Diane Newman, and I think you guys know her, and she has served many of you, and your students and families. So with insulin administration, again, the availability of the RN, provide instruction, specific delegation occurs, limits the UAP. We're really talking about UCAs here, aren't we, in this situation. Supervisory visits scheduled, that is important. It's part of the delegation steps, is a supervisory visit. You have to go and visit your UAP. If you're on another campus, you need to arrange that. You cannot delegate to someone without knowing what they're doing. Yes, we do our skills checklist, we do the demonstration and the return demonstration, but are you able to be sure that over a period of time what you have taught them is being done? So you have to arrange for a supervisory visit to be sure that that is being done. Additional visits as you need to, and then the documentation always. All right, tasks that prohibited from delegation. This is you as an RN. Number one, your assessment, your nursing assessment. No, you can't delegate that, and you have to do that part. It usually is involved in the very first assessment of a child and what do they need. And then, second, you begin to develop their care plans, your IHP and ECP, depending on what they need. Perhaps they need neither one. But if they do, you're going to go ahead and do that and then put it in your EHR. And then next is the responsibility and the accountability of health education itself. What are you teaching them? To be sure it's clear. And then dose calculation. I think you know what dose calculation is. We certainly use sliding scales, and that has already been calculated by someone, whether it's the physician, another nurse, and or yourself. But that has already been determined, so that is not a calculation to be done by UAP. They're merely following your directions. That when this happens, you do this. When that happens, you do that. Injectable medication with the exception of insulin, so we are not going to delegate any other injectables. Medication via non-permanent tube, that would be like an IV. Verbal and telephone orders, that's you. And then the initial dose is you. Emergency situations. This is when something needs to occur that would normally not be delegated, but must occur because it's an emergency situation. Tasks that require professional nursing judgment. Well, that you have already covered because you've already interviewed the child and the parent, talked to the family, and talked to staff, have an IHP in place, and an ECP that guides staff on campus in your absence. Please don't misunderstand that you, if you were the only one on campus, will be there every day. You won't be. Something's going to happen will take you away from that campus. Your staff need to be prepared to act in your absence. So, UAP may take actions that are reasonable and prudent, not non-licensed persons would take in an emergency. So what is reasonable and prudent? You make that happen on campus through your education and the way you break it down for that individual at that level to take that action. They're not going to do the same thing you do when you act in an emergency, but they can certainly call 911. They can certainly recognize when there's an emergency and make that happen. So, other things that they may do is Glucagon, Diastat, Epipen, MDIs, VNS, Nebulizer Treatments. They can do that when you are not there, but they have to be trained to do so, and when to know when to do it. Now you'll see that's actually in Rule 224.6. You need to look at 224.6, even though that really addresses the acute care setting, but there is some overlay from the independent learning, the independent environment, and it says so, that this is an overlay, and this also applies in this setting. Delegation by others. Again, the RN supervises the UAP, verifies their training, verifies that they can do the task safely, and adequately supervises. So, effective delegation is first communication. What is your communication between your UAP and you when you are apart? How do you communicate? How are you kept informed? Do they know when and how to call you? When they need to document something down? When they need to follow up with you on something? Have you taught them that? The second bullet is also important. Value the contribution of the UAP. I think sometimes that's overlooked. You're so busy telling them what to do, and they already may have a comfort level that is this big because they're doing something they weren't primarily trained to do. And they have to build that comfort and trust in you that you will give them the right information to do the task well, and they won't get in trouble. So value their contribution and certainly build that trust within them. And then the last, remember, it's a skill that they are learning. I've heard situations, again, not very often, where a school refuses to do anything. In other words, they want the nurse to do all the tasks and they not be involved. That's unfortunate because they are responsible for those students too on campus. But a lot of that will stem from the fact there is not a comfort level there to begin with. When the task can be broken down to be very simple, that they can understand, not you with your big nursing knowledge and medical terms, but you break it down to their level and make them feel comfortable at it, then the success occurs. So remember, teach UAPs when to report. Vital signs parameters, that usually is around medication. When there's a drop in mental status, what does that mean to them? They don't know what drop in mental status means. You do. But how would they recognize it? How would they know when to let you know? Urine output, low and high blood glucose. Okay, your resources is what we have mentioned earlier. The resource packet. In that packet, you have lots and lots of quick references, flow charts, all of the assessment grid. You have a lot of different things. Now, what we have done in health services is take that assessment grid and really broken it down for our setting. We've massaged that over and over. In fact, it grew from a one-pager to a four-pager, and we have to kind of bring it back down. But through the special needs school nurses, that assessment grid can be made accessible to you, and they'll walk you through it as you make that decision of what's going to be delegated on your campus and what is not. And when perhaps a private duty nurse is needed and when not. And when the TA in that unit does something and when not. So that particular tool, that assessment tool, has already been used about 10, 15 times, I believe, and is holding true. And to the best of my knowledge, we're the only district in Texas with it. And Melinda is very, very interested in it. But it helps you, again, we're assisting you to make those decisions on your campus. These are additional resources that you have. And then, of course, there's the contact information from Melinda. Now, I strongly suggest that you don't all email her at the same time. She is a woman that's difficult to get to, but first go to your nursing supervisor We have resources within our district, which we are very fortunate to have, and that's our special needs school nurses and our nursing supervisor over that area and the new supervisor to come. So you have extra resources that some districts don't have. So that concludes this portion on delegation.